In certain neurosurgical emergencies, the time we take to transfer a patient to a neurosurgical specialist center is critical. Time-critical neurosurgical emergencies such as extradural and subdural hematomas, posterior fossa bleeding and acute hydrocephalus should be transferred and operated on in the nearest neurosurgical center, even if this neurosurgical center has no intensive care bed. In order to get them to the nearest neurosurgical center, we need to ask the ambulance service for a transfer, which should be available within 15 minutes once we are ready to go. In certain neurosurgical emergencies, the time we take to transfer a patient to a neurosurgical specialist center is critical. This is particularly true for extradural hematomas, subdural hematomas, bleeding into the posterior fossa, as well as acute hydrocephalus. In patients with subarachnoid hemorrhage, the ones who have persistent unconsciousness possibly associated with acute hydrocephalus or bleeding into the brain itself or the ventricles also fall into the time-critical category for transfer to a neurosurgical center. During the limited time we have to get a patient ready for a transfer and to transfer them to a neurosurgical center, the ABC of resuscitation is again important. We have to provide a safe airway, oxygenate the patient well, ventilate to a low normal carbon dioxide level, and provide adequate blood pressure to perfuse the injured brain. In order to provide adequate blood pressure to a brain-injured patient, we have to remind ourselves of the normal intracranial pressure and the normal cerebral perfusion pressure. Intracranial pressure is normally below 15 millimeters of mercury. In an acutely brain-injured patient, it may be elevated to above 20 or possibly even above 30 millimeters of mercury. Cerebral perfusion pressure is the difference between mean arterial pressure and intracranial pressure. It normally ranges above 100 millimeters of mercury. In brain-injured patients, we should keep it at 60 millimeters of mercury or slightly above. And we have to remind ourselves that if the patient is slightly head up, we need to reference the arterial blood pressure to the level of the head. Cerebral blood flow has an impact on cerebral blood volume, and if cerebral blood volume expands in the injured brain, this may lead to a rise in intracranial pressure. Cerebral blood flow is strictly regulated by the brain's need for oxygen, or the cerebral metabolic oxygen demand. This will be increased by fits and by fever, and it will be decreased by low body temperature and deep sedation or anesthesia. Cerebral blood flow also depends on the arterial tension of carbon dioxide. And if carbon dioxide tension in the arterial blood rises or falls by 1 kilopascals, the cerebral blood volume will change by 15%. This is why our ventilation goal in acutely brain-injured patients should be a low normal PaCO2 of between 4.5 and 5 kilopascals. Cerebral blood flow also is normally strictly autoregulated between a mean arterial pressure of 50 and 150 millimeters of mercury. However, in acute brain injury, this autoregulation may be lost, and the brain's blood flow becomes more linearly dependent on the perfusion pressure. Another reason why it is so important to strictly control the blood pressure of brain-injured patients. When gathering all the information for an acutely brain-injured patient before their transfer, we can use the AMPO mnemonic. A standing for allergies, M for medications, which in brain-injured patients should include specific inquiry about any anticoagulants or antiplatelet drugs or any drug overdoses the patient may have taken. P stands for past medical history, so we should gather as much information as possible about the patient's prior medical problems. L stands for last oral intake. And E stands for the events surrounding this acute brain injury. Most patients with acute brain injuries who need to be transferred will need to be intubated. And when they get intubated, they should also have a gastric tube inserted under direct vision. And if there's any suspicion or a confirmed fracture of the base of the skull, it should be an orogastric tube. The gastric tube is important to decompress the stomach and for the neurosurgical center to be able to deliver important enteral medication. Just to recapitulate the situations where we definitely need to intubate patients. These would be the ones with a Glasgow coma scale below 9, a rapid fall in Glasgow coma scale by 2 points or more, any patients who cannot maintain good oxygenation. That would mean they have oxygen saturations below 92% or oxygen partial pressures below 11 kilopascals. Any patients with a raised arterial tension of carbon dioxide above 6 kilopascals or a low carbon dioxide tension below 4 kilopascals. And last not least, any patient with severe bleeding into their mouth or nose or severe maxillofacial injuries. For transfer, once intubated, the patient needs to be deeply sedated and receive good analgesia and neuromuscular blockade. This helps to control and avoid sudden surges in intracranial pressure and to ensure adequate ventilation on the transport ventilator. Suitable drugs for this include propofol, fentanyl, and atracurium or cisatracurium. Once intubated, acutely brain-injured patients should be ventilated to a PaO2 of above 12 kilopascals and a PaCO2 of 4.5 to 5 kilopascals. And we should not forget to take a chest X-ray to confirm the position of the tracheal and gastric tube and check for any pneumo or hemothorax. In terms of hemodynamic management, we have to remind ourselves that if intracranial pressure is raised to 20 or possibly more millimeters of mercury, then blood pressure, mean arterial blood pressure, will need to be 90 millimeters of mercury or above to maintain adequate cerebral perfusion pressure. This implies the need for wide-bore peripheral venous access, so at least 2 large-bore peripheral venous cannulae, volume, mainly as normal saline, and access to a fast-acting vasopressor such as metaraminol, which we may need particularly when the blood pressure drops acutely, for example, when we give sedation for intubation. Correct blood pressure management is also facilitated by having an arterial line, and ideally the arterial line should be sited before intubation, although in some situations airway control is more important than the arterial line and has to be done first. Central venous access can be very helpful to deliver continuous infusions of vasopressors such as noradrenaline and concentrated electrolyte supplements. However, we have to remind ourselves that in acutely brain-injured patients it is safest and quickest to insert a femoral line, and we should avoid internal jugular or subclavian lines. Multilumen lines in the internal jugular or subclavian vein may lead to obstruction in venous outflow from the brain. Their insertion may be associated with problems with the head-down position or with a pneumothorax, and an internal jugular or subclavian vein will not be accessible during any brain surgery. So in the neurosurgical emergency patient, only insert femoral lines and only insert them if you are quick at doing so. In patients whose mechanism of injury or clinical situation suggests a multiple injury, it is very important to assess and treat any other source of significant hemorrhage. So we have to assess for hemorrhage into the thorax, into the abdomen, the pelvis, and if there is such a bleeding source, it needs to be stabilized before the patient gets transferred to a neurosurgeon. In patients with non-traumatic subarachnoid hemorrhage, although we do need to maintain adequate cerebral perfusion pressure, We also need to remind ourselves that the highest initial risk is of rebleeding. So blood pressure should be maintained below a systolic of 140 millimeters of mercury, and we should avoid tachycardia. If there is a sudden rise in blood pressure, you should think of and assess for a possible rise in intracranial pressure. As intracranial pressure rises, the brain will need higher cerebral perfusion pressure, and this is why the blood pressure is rising. Another reason for an acute rise in blood pressure may be a seizure, which due to the sedation and paralysis, we may not see as muscle contractions. So in neurosurgical emergency patients with sudden rises in blood pressure, assess and treat for potentially rising intracranial pressure and seizures. In order to control intracranial pressure and cerebral blood flow, we have to provide the neurosurgical emergency patient with deep sedation and analgesia. We should also ensure normothermia and treat any fever, and we should prevent or treat any seizures. Seizures are particularly common in patients who have subdural or intracerebral bleeding. To prevent seizures, we should administer a loading dose of phenytoin of 15 milligrams per kilo, which in normal adults translates into about a gram or 1.5 grams. Keeping the head slightly elevated between 15 and 30 degrees and in a neutral position, as well as avoiding any constricting ties for the endotracheal tube, will help optimize brain blood flow and avoid any obstruction to venous outflow from the brain. An acute, possibly life-threatening rise in intracranial pressure may manifest itself with dilatation and loss of light reaction in one or both pupils. So what should we do when the pupils suddenly blow? In the first instance, deepening the sedation will help to reduce intracranial pressure. So we should give a bolus of sedative and increase the infusion rate. But also bear in mind that this may lead to a fall in blood pressure, which we may need to counteract with a more volume and vasopressor. Another measure we can adopt to reduce intracranial pressure acutely is to hyperventilate the patient to a PaCO2 of 3.5 to 4 kilopascals for a short term. A third option to treat acutely rising intracranial pressure and dilated pupils is high-dose mannitol, up to 1 to 1.4 grams per kilo body weight. If we remind ourselves that a 20% solution of mannitol contains 20 grams per 100 milliliters, for a standard size adult of about 80 kilograms, we would need 400 milliliters of mannitol to provide 1 gram per kilo body weight. Last not least, if the pupils dilate acutely, we need to make our transfer even more quick, and we need to inform the neurosurgeons and get their advice. So what are the key points of transferring a patient with an acute brain injury? First and foremost, good control of airway, breathing and circulation. Avoid hypoxemia and hypotension at all times. Assess and deal with any significant bleeding from other injuries. And get your neurosurgical patient to the neurosurgeon in the shortest possible time and with the best possible communication to the receiving center.